Welcome to the End of Life Option Act Response Conference. My name is Barbara Koenig, and I'm a faculty member at UCSF and part of another group called the UC North Bioethics Collaboratory. I've had the privilege of working with a great team of colleagues in putting this conference together, and I'll say more about them in a few moments, but I'm going to start by trying to do a general introduction. So the first thing to point out, I'd like to just make it very clear that everyone in this room was specially selected to participate. So you're a very amazing group of people. We want to thank you for giving up a Saturday during this exceptionally busy time of year. But we felt great urgency in hosting this conference early enough to allow our work together today to shape institutional policies developed by healthcare systems across the state. And indeed, that is our mission today, to promote thoughtful deliberation on the challenges and opportunities we face as institutions respond to the End of Life Option Act in California. I want to start by offering a word of thanks to Kate O'Malley, a senior program officer at the California Healthcare Foundation, who unfortunately can't be here today because of a vacation, which is a good thing. But I want to thank her for her immediate enthusiasm when I proposed the idea of getting together ethics and palliative care communities from across the state. Literally the week before Governor Brown signed the bill on October 5th, I wrote to her proposing this meeting, and she shepherded the proposal through to funding, but with an actual award letter of November 2nd. So you see, this has been very, very fast. So to use a metaphor, we have been building this train of this meeting and this response conference while it rolls down the track. We put the conference together in less than 2 months, so I think about it, imagine a sort of skeleton of a boxcar with all of us running alongside, jumping up, holding on for dear life while we booked hotels, identified speakers, sent invitations, developed workshops, etc. So I probably need to start with a generic apology for all the things we failed to do while we were hanging onto that boxcar, because in our haste, we may have missed a particular health system or critical individual, or we may have not included a topic that you consider critical. So forgive us if that's the case. And please let us know, and as we move forward to create ongoing collaborations across the state, we will take your suggestions into account. And indeed, creating such collaborations and resources is an additional goal of today's conference. So how did we begin? We started by establishing a steering committee, a group of distinguished advisors from throughout the state reflecting disciplinary diversity, diversity of health systems, public, private, Kaiser, religious, etc., as well as diversity of opinion about whether aid in dying should be enshrined in law. In a series of conference calls, the steering committee members offered us critical advice as we began planning. And their names are noted in the attendee list in your conference folder, and we thank them for their help. But of course, our smaller planning group takes full responsibility for the final product. I'm going to quickly show you two slides, so I need to have that down. So we had some initial questions when we started, and I'll go through that really quickly. These are just in no particular order. How will pharmacies respond? How will healthcare organizations that elect not to participate respond? How will healthcare organizations manage conscientious objection? And how can we plan for the needs of diverse populations? Whoops, I did them in the wrong order. There we go, we'll go back. How will individual clinicians be educated to respond to requests for physician aid in dying, a very important issue? How will required legal safeguards, such as the establishing of prognosis and second opinion, be implemented, as well as the new and unique final attestation piece of the California law? And how will decision-making capacity be assessed? But before moving into that the meat of the conference, I would now like to take a few minutes to address a central question. Why is this such a hard topic? Aid in dying laws and policy have been steeped in controversy. Well-meaning people have strongly felt beliefs, and people in the room today have very, very different views. The issue is also deeply personal, based on painful memories of the deaths of family members or patients, and the issue is inevitably political, as any controversy over rights and life is in our society. Even seemingly simple word choice conveys the controversy. We have struggled on our small group over language. Are we implementing or responding? Do we use the term physician aid in dying or not? Different communities can be hurt by careless language. I feel like a personal embodiment of the controversy in some ways. Prior to legalization, I was an opponent of changing the law, not because I felt it was inherently unethical, rather my concerns had to do with promoting a right to aid in dying in a country without universal access to health care. And I see people nodding about that. I'll admit I remain deeply ambivalent. How will aid in dying transform the role of healer? Might diverse Californians be harmed at a moment of rapidly increasing economic inequality? There is an emerging body of research from Oregon and Washington suggesting that harm has not been documented. But whether harm has occurred is not an easy question to answer and doesn't suggest that we shouldn't use caution in California and carefully chart that. In fact, I've been on both sides. I'm embodying the controversy. But I also worked on the first set of studies that followed patients requesting aid in dying in Oregon and Washington with Helene Starks, who you'll hear from later. So I understand the heartfelt desire, having followed those narrative accounts, I understand the heartfelt desire of patients to exercise autonomy and control. And lastly, I benefited from multiple conversations with close colleagues such as Bob Brody from San Francisco General, who has actively advocated for the law. We talked through conference goals and objectives over several long sessions at the UCSF gym. Just to make it clear that colleagues can talk about this in odd places. And we were hopefully modeling the collegiality and civil discourse we hope will be the norm today. And I'd like to take a few minutes to poll the room to get a sense of if we have successfully captured diversity. And I have a couple questions that we're going to use and do in audience response fashion. And this is to get a sense of the diversity in the room. So, do you personally oppose or support the End of Life Option Act? If you opposed, push A. If you support, push B. And if you're neutral, push C. So oppose is 16%, support is 53%, and neutral is 32%. So that's interesting. Let's try the next question. Let's try the next one. If a patient were to ask you for aid in dying, would you be willing to provide it? A is yes, B is no. And start clicking. Okay. So again, we do have some diversity in the room. That was the main point of this. So here are the answers to this first one so that you can actually see them. Have you had a patient ask you for aid in dying? And we have 79% of people saying yes. So this was supposed to demonstrate that there is diversity in the room. And then how do you proceed? So the next step is for all of us to agree to suspend disbelief, to move beyond our past commitments, and talk together productively about next steps. We have come together today because California has a new law. That is the fact on the ground. Although we're not sure about the exact date of implementation, and there still may be initiatives to delay that date, all California healthcare institutions will need to respond to that law. That is true whether a particular institution decides to offer aid in dying as a routine part of its practice or not. So the bottom line is we are no longer in lobbying or activist mode. This conference is not about either celebration or lamentation. It's about response at this moment. So I'd like to next talk about the ground rules we've put together. But before doing that, I'd like to propose that there is one topic on which we all agree. I believe that we all agree that no one should exercise this new legal right to physician aid in dying because of lack of access to the highest quality palliative care. We can all agree that high quality palliative care should be the standard of care for seriously ill and dying patients, and we should continue to strive to make access a reality for all Californians. So let's keep that in the background as we deliberate today, that we have shared understandings. So the ground rules. Given that this is a hard topic for many people, and I will say that it may not be apparent now, but I've had meetings where people are in tears, and the battle to enact this law was hard fought over many years. I'd like to propose ground rules that are in your packet on an orange sheet. And note, it's really very simple. First, treat everyone with respect. 2, try not to rehash old debates, but to move forward. 3, note that some people are sensitive about how their participation may or may not be reported or represented. Even just being here is an issue. So we would like this conference to be governed by what are called in the UK Chatham House rules, and those are described, meaning that what it takes place in this room should stay in this room. We are videotaping just the plenaries and in order for them to be available to those unable to attend in person today, and the speakers have granted permission. If you do not want to be captured on film, don't speak during the question and answer sessions that we have. Instead, place your questions or comments on a piece of paper and pass them to one of our volunteers. We have invited several journalists to the conference, but ask that they consider their observation of the meeting as on background and only quote individuals with their express permission. So we have a set of ground rules about journalists. And we also, we have established a Twitter feed for the meeting, and that's the hashtag for those of you who are interested in standing for End of Life Option Act Response Conference. So for those of you who want to tweet your reactions during the day, you're welcome to, but we ask that you do not use the names of individuals or institutions in your tweet. And I should add that I had to be pushed to have this hashtag, so I'm overcoming my Luddite tendencies. A few other words of orientation to the day and orientation to the materials in the folders, because we have very little time together. Today, we won't be doing elaborate introductions of panelists and workshop leaders. Note that there are brief bios included in your packet, and there is also a list of all the conference attendees and speakers. And again, Chatham House rules, please use this list only for follow-up on matters related to the conference, not for mailing lists, etc. We hope to use this conference to launch a research agenda to study how California responds to the Act, and we plan to write up this meeting. So you'll notice note takers going around the room who've been trained to take notes. So there is a description of the research component in this folder, and we hope to collect some basic demographic information about who actually came to this initial launch meeting. So we'd also appreciate your completing that anonymous demographic form. And then there's some other sort of more mundane details like a map, a reimbursement form, but very importantly, a summary of the law. So hopefully those will all be helpful. And be sure to pick up a parking coupon if you drove today. So before we get down to work, I want to thank the very talented team of colleagues and staff in our bioethics program at UCSF who came together under very short notice and put together today's meetings. Liz Zhang, a hospitalist and a PhD in sociology who studies end-of-life care. I'm going to ask people to stand so people know who the planning committee was. Laura Pertillo, an internist certified in palliative care. And Lindsay Forbes, our multi-talented bioethics program manager. And Marie-Christine Yu, also, I think, who just came in the back, who assisted. And finally, Ben Scribner from the UCSF Nursing Health Policy Program, who recruited and organized the many volunteers you will encounter today. So they'll have a second name tag that says observer and or volunteer. And I'd like to thank them in advance for their help. So a final audience response questions. Let's see if we can do it once more. And this one is, imagine that you're doing a Likert scale. How prepared is your organization to respond to the Act? And A is very prepared, and D is unprepared. And so wait to start clicking until we say go. Go. And I should say we're going to repeat this at the end of today. Okay. Goodness. Okay, that's pretty clear.
Do you want to go
that's
back to
helpful.
The other questions?
No. Okay, we'll see if we can move the needle on that. Have a great day. We'll begin with a series of panels presented as plenaries and then break down into smaller groups for workshops in the afternoon. And please let any of the organizers know if you have questions or concerns. And I'm now going to turn it over to Laura to moderate the next session.
Good morning. So this panel is Perspectives from Oregon and Washington. The history of the law concerning physicians hastening death in the United States is long and colorful. Bans on assisting a suicide date back to mid-1800s, and laws to permit euthanasia have been raised, debated, and defeated several times throughout U.S. history. Our attention has been captured by such polarizing figures as Jack Kevorkian and Brittany Menard. In 1994, Oregon became the very first state to make it legal for a terminally ill person to request medication to end his or her life from a physician. Like every other time that this issue has been discussed, there was tremendous debate. And once the Death with Dignity Act went into effect in 1997, the whole country was watching Oregon. It's been 18 years, and from what we can tell, there have not been massive abuses of the law or movement towards euthanasia or making the option available to non-terminally ill people. The number of people who use the act continues to be quite small. End-of-life care has actually arguably improved in Oregon as a function of the healthcare system coming together to respond to this wake-up call that end-of-life care was not meeting patients' needs. And the experience in Oregon was reassuring enough to their neighbors to the north that Washington State adopted a law in 2008. We're at a moment now in California where the End-of-Life Option Act has just become law, and the healthcare community needs to come together to be ready to respond. There is still plenty of concern and a sense of uncertainty about how things will go in California. But we're coming together today to use this as a moment of reflection and to think about how to take this opportunity to make healthcare better for seriously ill patients in California. We're going to start the day with this panel with perspectives of 3 doctors from Oregon and Washington who all had incredibly active roles in responding to the changes in their states and who have stories to tell. We look to them not to say, tell us what to do next, but rather to ask, what was your experience? What patterns did you see in the data? What challenges did you face? What resources were there for you to care for your patients when they came forward to ask for a prescription? And what did you have to do to figure things out on your own or create new systems to respond? I'll end my comments with just a reminder that we have people both in the audience and at the podium who have very different views on this, and we're going to try to maintain just a tone of collegiality and respect, and just to emphasize that we're neither condoning or condemning the law, but trying to figure out how to achieve the best possible care for seriously ill patients in California. So I'm going to introduce our panelists, starting from the left. We're extremely fortunate to be joined by Dr. Katrina Hedberg. She's joining us from Oregon. She's the Oregon Public Health Officer and State Epidemiologist with the Division of the Oregon Health Authority. Dr. Hedberg trained at Oregon Health and Sciences University. She did her Master's of Public Health at University of Washington and is board certified in public health and preventive medicine. Dr. Hedberg established the reporting system for the Oregon Death with Dignity Act and is responsible for issuing the annual reports. A lot of what we know about what happened in the early years and what continues to happen in Oregon is thanks to Dr. Hedberg. She's published numerous articles on the experience, and she has a particular interest in making public health data available for policy and decision making. So welcome, Dr. Hedberg. Next, we're joined by Dr. Elizabeth Loggers. She is an assistant member of the Fred Hutchinson Cancer Center in Seattle. She's a board-certified hospice and palliative medicine physician and also a board-certified medical oncologist. She's director for the supportive and palliative care center at the Seattle Cancer Care Alliance. And one of the things that we particularly want to highlight today is that Dr. Loggers was involved in an effort to create an implementation program at the Comprehensive Care Center of the Fred Hutchinson Cancer Center, and that article has been a very influential and helpful article to look to, and we hope that she'll speak about that experience. Lastly, to my left is Dr. Peter Reagan. He's a retired family physician from Portland who trained at OHSU. He, as I'm sure will tell you, holds the distinction of being the first to write a dying prescription in Oregon. He served on the medical staff at the Adventist Medical Center and has an appointment as assistant adjunct professor of family practice at Oregon Health and Sciences. I will note that he is also an advocate currently for the organization Compassion and Choices and one of their medical directors. So we're going to start with 5 minutes from each panelist, and then we're going to open the room to questions. I ask that when you do ask questions that you just state your name and if you feel comfortable and your affiliation before asking your question. And there'll be runners with mics. Dr. Hedberg.
Yeah.
So thank you. My pleasure to be here today. As Laura said in my introduction, I'm actually not an expert in end-of-life care. I'm an epidemiologist, so we look at patterns of disease and distribution in the population, and it's been very interesting to me to do that related to, for example, risk factors for cancer, tobacco use, et cetera. That's kind of my day job. And so the way I got involved with this is that in Oregon, the law passed, actually was voted on twice, but for the second time it passed in 1997. And it assigned to us, it was a citizens initiative, so that's different than California, where it was voted on, and it assigned to the Public Health Division the task of keeping track of participation and compliance with the law, and then issuing an annual report. So again, a lot of people say, well, you know, why are you involved, or how did that? It's because the statute assigned that specifically to us. So there really isn't any program, if you will, in Oregon. The Oregon law is what I call permissive. It allows qualified patients to request a prescription, and it allows physicians to write that. And again, there are a number of other providers, but that means it also allows anybody to not participate, et cetera. So there isn't any program. I do have people who call me up and say, I want to sign up for your program. I said, there isn't a program. It's a permissive law in Oregon, and it's up to you. You know, again, we keep track of the data on participation. So because it assigned this task to us, I didn't really know how to approach it other than, as a good epidemiologist does, well, so it's sort of time, place, person who's participating. But we were lucky that our Center for Ethics and Healthcare at Oregon Health and Sciences University pulled together what was called the Task Force to Improve Care of Terminally Ill Oregonians. And the idea there was that if this law is in place regardless of where you are in the spectrum. If a patient asks you this question, now what? So sort of delving into those kinds of things. I was, and came out with a guidebook related to this. And it was less a how-to manual and much more, if the question is asked, what are the things that you need to consider? The time is going to be very short. Again, with the reporting system, we relied on that group, and also we write administrative rules with statute, so it's a public process, get input. And with that, we developed a reporting system that really relied on not reporting every conversation, but rather if a patient had gone through all the steps up to the point a prescription was written, that was the time that we could put a reporting system into place. So we get information on the prescription. Then, because we're the vital records department for the state, we get all the death certificates, and we can match those two. So we know which patients took the prescription when they have died. And then we have a follow-up questionnaire. But again, the statute in Oregon really only addresses the points up to the prescription is written, and the other parts of our reporting system are done as part of our general public health mandate. So just briefly, the data in Oregon, and I know there have been concerns that at least initially people were saying, well, is this going to be sort of poor? Is this going to be people who are uneducated? Are people going to be coerced? And of course, the data in Oregon actually show the opposite, that more than, it's around half the people have college graduate degrees. People tend to be very assertive, and this is something that they are really want as a choice. The median age is 70. And it's overwhelmingly white. That may be a little bit different than California. We are a mostly white state. We now have about 12% Hispanic. But again, the majority of the people who have participated have been white. In addition to this, of course, as I mentioned, compliance, we do look at the compliance. We are not the people who do oversight. And at the beginning, I said, well, it's, for example, in Oregon, we have a 15-day waiting period. And I said, well, you know, you put in a waiting period. What if somebody only waits 14 days? I didn't want to be in a position of saying, well, that's close to 15, but what about 13 or whatever? So any case of noncompliance that comes to our attention gets reported to the licensing board. Now, over the years, there have been 22 cases where we have had to report physicians to the licensing board. The standard that they have is different than, again, in public health. I'm sort of, you know, the letter of the law. The licensing board looks at whether or not the physician acted in, quote, good faith compliance. And so they do an investigation and have found that in most of the cases, it really is a question of the paperwork or the forms haven't been filled, but things like there may only be one witness, et cetera. But again, the licensing board has not sanctioned any physicians who've participated. We also collect some data on the circumstances surrounding the death. Now, in the past couple of years, we used to collect that from volunteers and other people who were present at the time of death and family, but we have changed that to only be healthcare providers, in part because we really don't collect medical information about circumstances that are happening in other situations by family or volunteers, et cetera. So that is something we have less information, and might be, folks again have asked us, why don't you do this? And we said, well, we are trying to approach this much as similar, if you will, as we do with reporting for other diseases and conditions that we collect data on. So I'm just going to end very briefly. I see the time, but you know, people also ask me about my views, and my views, as was said already, are really that data are important to inform the debate, but they aren't going to answer the question about should there be a law or not, or what are the ethics. I think it's very clear to understand that in Oregon, as I said, it's a permissive law, so when people ask about oversight, I know that opponents of this law really want there to be more government intervention, et cetera. And the advocates can say, no, this is fine. This is giving patients a lot of control. And so when, you know, that comment is, as a government employee, my job is to carry out the law as it's written. And if people don't like the law, they need to change the law. It's not up to me to go beyond the reaches of what was explicitly. And again, that hasn't been my decision. We've actually gotten our Attorney General and others to weigh in on what our appropriate role should be or not. So again, as been talked about with this conference, I really do think the silver lining is that people are talking about what you want at end of life. And if you don't want this to be an option, make sure that everyone has access to palliative care, to choices, to hospice, and everything else at the end of life, so that they, again, can live life to its fullest. So thank you.
So I want to just clarify that the Fred Hutchinson is a cancer research center. The University of Washington is the academic hospital. The Seattle Cancer Care Alliance is the location where adults with cancer receive their outpatient care. So I'm going to be speaking from the perspective of someone who's participated at an institution that has implemented the policy. So patients at our institution do have access to physician aid in dying. I did publish on this. This was published in the New England Journal of Medicine in 2013, and I would send you to that article to learn more about the body of our policies. I'd like to just reiterate that our experience and the experience in Washington was very much, as you've described, Dr. Hedberg, thank you for that. We find that our patients are largely white, male, well-educated individuals who have been in control of their lives, their entire lives, and come to the end of life with that same perspective. They generally have talked with their family, and everyone is well aware, often well in advance of them actually dying, you know, being close to dying, that this is something that they intend to employ. So I think what I would like to stress is a few things from our experience. One is, you know, I also come at this as a palliative care physician as well as a medical oncologist, so I've been on both sides of this. And it's important to just keep in mind, at the heart of whatever your policies are, if you decide to march forward, that you're going to have probably, like our institution, a third of people who are against this, a third of people who are willing to participate, possibly as a consulting attending, and a third who are willing to do both the attending and consulting role, which means that you'll be faced with an institution that also has mixed feelings about this. And that goes to every person in the building. That means that the nurses have mixed feelings. That means the pharmacists have mixed feelings. That means your palliative care providers have mixed feelings. And you need to get clear on who is actually going to be able to work with these patients in a respectful way and really optimize what they can learn. None of these patients have gone through this before. They are all naive, and they need your help. And what they need is really a palliative care boot camp that happens in 2 short weeks, because you have 15 days to really bring them up to speed on what does it mean to die, how will I know that I am, what will I experience, how can you ameliorate those symptoms, and so I want you to really think hard about what processes can I build, if we are going to participate, that help shepherd that person and their family through this. I'd also like to say that every policy has unintended consequences, and so you should go into this expecting that you will rewrite your policy, hopefully numerous times, each time refining it and perfecting it so that everybody gets the best care. What I mean by that, for example, is that you can create things that you think in the beginning make quite a lot of sense, and then the individual circumstances bring to light ways in which you never thought the circumstances would play out. So examples of that can be destination patients who come to you who have never received care in your walls and now would like to have aid in dying. And so you don't have a physician who has a relationship with them. As an institution, we've said we would not care for these patients in this way. We'd happily care for them with palliative care. We'd happily refer them to hospice, but that we wouldn't participate for people we didn't have a long-term relationship. You can imagine that can be incredibly angering for patients who came with the expectation. Some people who weren't even residents 15 days ago, for example. So please do think about these things. You also need to think about the occasion in which your attending physician and your consulting physician don't agree on the prognosis. We've elected to ensure in our policy that the patient is alerted to that, and that data are brought to them about what prognosis looks like and about when they are likely going to be becoming more debilitated. I'd also suggest that one of the things that we've done in Washington informally, but is to meet together as institutions that are providing to talk and debrief, and to talk about the cases in which we find this troublesome and why. And some of those cases that are most troubling, I think, tend to be cases in which the attending physician is not necessarily a physician caring for similar patients, meaning this person isn't an oncologist, but is writing for people who have cancer. Your law specifically says the attending physician of record is managing that patient, but also is treating their particular condition. And I think that that's an important piece of knowledge. We all can fall behind in our knowledge, and as medicine advances, I think that's quite important. But that community also helps. We've also realized that this is difficult for hospices, many hospices. Largely in Washington, our hospices have been willing to continue to provide and have turned sort of a blind eye to what might be happening within, and many are quite supportive. But there are many religiously affiliated hospices who also can want to provide the best possible care but feel conflicted about this. So there's a lot to think about, and I would say just keep in mind at the center of it is that patient, and there are wonderful resources about how to approach that patient. So, thank you.
So in 1998 in Oregon, the guidebook that Katrina had mentioned was available to those of us in practice, and there was a very small compassionate dying organization, and then again, there was an occasional person you could find who would be willing to share experience with aid in dying on a more clandestine wink and nod basis, as it's practiced all over the world, I guess. Many larger organizations in Oregon had already taken a stand, as were described, some actually very welcoming in the sense that Hutchinson has been, and others that were very crisply opposed. There was certainly any kind of available experience to help us deal with our own reactions and feelings. And at the time, I was in a really active family practice, and I had a lot of obstetrics and a lot of young families, and was good friends with one of the original proponents, Peter Goodwin. He asked me to see a patient who had contacted Compassion in Dying of Oregon a few weeks earlier, who was interested in aid in dying, and she actually became the first patient in the United States to receive a legal prescription. I wrote about her in a Lancet article in 1999. So at the time, my evaluation for her, I met her 2 weeks, or a little more than 2 weeks before she died. I had 2 office visits. I had a house call. I arranged the specialist consultation as well as a mental health consultation, first case ever. Not that I knew it at the time that it was the first case. I spoke with all of her previous doctors. I talked with her hospice workers. So I knew I had a lot of different eyes on her. And then I met with her family members. Since that, legal practice has been clarified through more rules and regulations in Oregon. There's a nice summary of each year's experience that Katrina's department is responsible for, and there's been gradual evolution of acceptance and support by various larger healthcare providers in the state. Compassion, I think, more by default became a clearinghouse for clinical and pharmaceutical information, as well as developing a robust program of volunteer support for individuals. And as also a confidential referral service for patients whose own physicians were unable to engage in the discussion with their patients, either because of their employment arrangements or their own feelings. Aid in dying now occurs in the course of medical practice. It's not something that's in the newspaper or argued about. It's certainly not a public practice, but it's, you know, any case involves family. It involves hospice employees. We've certainly had any number of hospice employees present at the time of death. It involves friends. The other medical providers that have cared for the patient over the course of their illness are certainly involved, and they know about the decision, and they can weigh in if they don't think any observations are appropriate. So the events are not clandestine any more than any other medical treatment in the state. And they're more thoroughly followed and studied than any other practice, because there is also, on top of that, the mandatory reporting system that Katrina's involved in. We did not know at the onset what the complication rate might be, and at this point we can say that once a person has ingested lethal medication, the time to death is in the range of an hour, but maybe 15% stay alive longer than 8 hours, and about 1% seem to live beyond 24 hours. And may appear to begin regaining consciousness. So what have we learned? What we've seen so far is that there will be some demand. Okay, there are people that want this. It's not numerically overwhelming, but some individual cases will be very, very compelling. Some patients feel that they have a right to access this practice, and the truth of the matter is no law in the United States grants that right. Right. What the law does is gives the family and friends and providers the right to decide to help a qualified person. It does not give anyone the right to access. It's critical to appreciate the value of permission to discuss these issues. This is a door that is now open that did not used to be open. And without legality, it was a huge favor for a patient to ask their doctor or their family to discuss breaking the law. And if asked, you are now allowed to explore these issues without fear of legal consequences. So the conversation can be more real. And this is something that this is a right that everybody has now. And I encourage you to notice that the door's open, at least to be able to talk. It really changes the conversation, or it can. And that's why who benefits from our law, we talk about 0.2% of people, quotes, using the law in order to end their lives. Everybody else uses the law in order to have a better, more open discussion with their family members and their providers, and that's what the law is for. Oh, okay. And so I'll just say one more thing, and that is that we find that that patients going through the process of the law find it cumbersome and frustrating, but they find it much, much more cumbersome and frustrating when they need to find new physicians at the end of their lives. So figuring out a way to respond to a patient's very carefully considered request at the time that they bring it to you, I think will really help them feel better. And the only other point I'm going to make is just the observation, having provided prescriptions for people. You provide a prescription for a person, and you watch what happens to them and their family when you say that you will do it, and they are so relieved. They feel so much better. They're palliated. Just wanted to make that point.
So I'm just going to go ahead and ask for questions from the audience.
Hi, Susan Penny, Director of Risk Management for UCSF Health. I have lots of questions, but I'm going to try to just ask three 3. So when this passed, I did not contemplate that the giving of the meds and the taking of the meds would occur within the hospital building. And then the reporting form has place of taking, and it includes a hospital setting. So my question is, for those of you who've been at this for a while in Oregon and Washington, has it been done in the hospital setting? I'm the risk manager for UCSF, so that's an important question when we develop our policy. And do you have special credentials for people who are doing it and require that referral to palliative care? It sounds like the boot camp is mandatory. And will you share your policy from Fred Hutchinson, or is it available online? Thank you.
So I'll answer your first question, not all of them, but in Oregon, and I did bring the report, it's on our website. It's healthoregon.org/ if you go to healthoregon.org, that's the Public Health Division homepage, and Death with Dignity, there'll be a click there, you can get to the page quickly. But basically, the vast majority of patients, 95%, have died at home. A little over 4% have died in long-term assisted living foster care facilities, so rather than their own private residence. And to date, we've only had one patient who has died in a hospital setting, and that is a hospital that is certainly aware that this was happening, so it's not that our Catholic hospital suddenly had someone, or the VA isn't also, because it's a federal hospital, wouldn't allow it. So it was, everyone was cognizant that this was something that was happening. So that's what the statistics show.
Yeah, the Seattle Cancer Care Alliance is an outpatient facility. While it's considered a hospital, there are no beds. Our beds are at the University of Washington, and as you can imagine, not every institution feels as comfortable with this as the leadership at the Seattle Cancer Care Alliance did. There have been requests. In general, we also, as an organization broadly, try to encourage people to be in hospice at home, but my understanding is it has happened at least once within the University of Washington. But it's not encouraged.
Yeah, and just the Oregon statistics on hospice, patients, the law states that they're required to be offered hospice, but not, of course, everybody takes that offer up, in part because, at least in Oregon, I don't know how it is in California, but the vast majority of our hospice is in-home hospice service. You get a hospital bed, et cetera. There are a couple of inpatient hospices, but that's really unusual. So the hospice care is being done in-home. Oregon Hospice has taken a neutral stand at the association. Of course, they're individual hospices. But my feeling is that, again, even if hospice is opposed, they don't necessarily turn the patient away. They want to provide as good services, and it may be that they're not present at the time of death, but it's been more that they've wanted to continue to support patients in hospice.
There were other questions embedded within the question. One of them was around our policy and whether we would share it. I am willing to share it. I have to say it is still not what we wish it was. There are still many things that are not explicitly written in it that are practices within the building. There are many reasons for that, but we are happy to share that, and I think my contact information is in the packet. So. There was one other question, and I'm sorry I can't remember it. Does anybody else remember it?
You have people be credentialed.
Oh, sorry. There is no particular training or credentialing at our institution. We require that patients are referred to the social worker, and at the Seattle Cancer Care Alliance, the social worker is the first line of mental health evaluation. So they perform all of our initial evaluations for mental health and do that both informally and formally with patients. So every physician attending and consulting physician are shepherded through the process by a social worker in addition to the patient and the patient's family. And that is how we have elected to ensure that the standards are being met. Palliative care is not formally required. It's encouraged at our institution.
Lori Dornbrand, geriatrician. I was intrigued by your mention of death certificates in which physicians are notoriously ill-trained. What are there rules or policies about what the death certificate should read?
Yeah, so we make recommendations as to how death certificates are filled out, but there isn't any very sort of specific requirement. The issue with death certificates, as you're all aware, is that they're really, the primary purpose is as a legal document and to settle the estate, to confirm the fact of death, et cetera. And so they're sort of secondary use for what we would, public health purposes, et cetera. So what we suggest that people write on the death certificate, because it is a legal and relatively open document, is that they write the underlying disease. But again, we match those with prescriptions, and then we query the physician about whether the patient took the medication. And the analogy I use here is, for example, if someone is in a car crash, is in a coma, and the family decides that they're going to extubate the patient and no more feeding tube, we don't write, pulled the plug. You write, they died of a massive head trauma secondary to a car crash. So in terms of the medical intervention, we want that information, but because the death certificate is a public document, I think one of the concerns about this, and I know there have been some comments about sort of the openness of the process or the death certificates. Early on, when this was, obviously we were the first state, I know we had queries sort of monthly after it was, has the first case happened, because reporters in the media were really combing obituaries to try to identify who the first case was. So again, as a public health agency, we really believe very strongly in the confidentiality of individuals. There certainly have been a number of individuals, as we know, who've gone very public in their advocacy for this. But because we don't want to be the ones who are disclosing any of that sort of personal health information, et cetera. So that gets back to the death certificates, that we want the data, et cetera. Obviously, the family feels strongly they could put participation in death with dignity secondary to pancreatic cancer or lung cancer. But again, our recommendation is that they fill it out in terms of the underlying cause of death.
I just want to take the opportunity to say, the intent of the law in Washington State is clear regarding the death certificate, which is that it should reflect the underlying disease, and that you are not to put death with dignity on the death certificate for legal reasons. I'd also like to take this opportunity, I know this wasn't asked, but I just want to, just for the clinicians in the room, you also need to think thoughtfully about where you're documenting this, because this is also supposed to be documented in the medical record. And we've had cases where, documentation is sort of within the body of any other clinic note, right? Because some of these patients are still receiving treatment, some of them are still visiting you. And keep in mind that many of these people are self-insured, so these records are open to their employer. These records are open to their daughter from, we always say California jokingly, but New York, since nobody, who asks for the record and all of that. And so, we recommend that people would document this in a separate note, and then not necessarily continually documented in every clinic note that the patient is participating in that process or has received the medication.
All right, we're going to take a question from Holly Swagger.
So for follow-up, in regard to tracking this from the statistical perspective, I understand how you would have knowledge of who had requested the prescription and that there's reporting there. But since the death certificate does not record that, how do you know whether a patient actually ingested or not, or whether the family wanted to keep that quiet or the patient just died of natural causes?
Yeah, so again, for our purposes, we know about the prescriptions written, and there's two parts to that. The statute was amended one time in Oregon to include a reporting from pharmacies at the time prescriptions were dispensed. And so that, if you will, is kind of a belt and suspenders. We occasionally get a pharmacy that says we've filled a prescription, and then we go back to make sure that we have the reporting from physicians. So, if you will, the statute itself, and I really have to be clear, only talks about the point up to the prescription is written, and that's what we did, the sort of basic reporting under Death with Dignity. We, in conjunction again with the task force and with others, this public process, realized that people didn't want to just know how many prescriptions were written. They wanted to know how many people took them. So I mentioned that we have death certificates. All of those come to us, and we match them. The third part of our reporting system is that once we match, we request that physicians who wrote the prescription fill out what we call a follow-up form. All of these forms are on our webpage. The process is there, and it's the physician who then we rely on. But I have to tell you, they don't necessarily know in every case. Because, again, a patient might, long-term relationship, and the doctor might retire. And so, you know, that kind of follow-up they may not know, or the doctor may move out of state, or, you know, somebody else might die and, you know, they lose track. These things happen all the time. So to be clear, our reporting system helps to protect, but at the same time, it is a passive reporting system in the sense that we don't have a team of investigators to go out. We don't have that kind of oversight. So we rely on this. And what I say is I actually believe very strongly that we get pretty complete reporting, because if you follow all these steps and report to us, then you're protected under the law. And if you don't follow the steps, you're not. So that's a strong incentive to do the right thing. But we do know that we have cases that are lost to follow-up in Oregon.
Thanks. I wanted to put a little stake in the ground. At the table, you represent San Francisco, Seattle, and Portland, and I live in Humboldt County. 2/3 of the people in the state of California have no access at all to palliative care, and 22 of the state's counties have no palliative care present. The hospice average length of stay is at about 2 weeks or less. And so there's this vast population of Californians who may wish to take steps in this direction, and we're really weak in terms of our responsiveness. And the pressures that will be felt in rural or communities may be more acute and idiosyncratic in how communities respond. So I wanted to just put that stake in the ground. I think that's why I'm here today. And
Thank
it'll
you.
be
And
through
did you
the
have a
day.
question for anyone on the panel?
Nothing specific. No.
Okay.
So, I know that didn't necessarily require a response, and this isn't a direct response, but I just do want to mention that in Washington State, we are a very diverse state, with the west side of the state being much more metropolitan, much less rural, much more white and well-educated. The eastern side of the state is more rural. And what we found is that the vast majority of these cases come from the west side. And in fact, most of the people, since the law was enacted on the east side, don't have access to it because nobody will provide it. So that is partially because it's rural. It's partially because of differences in politics and views. It's also because of limited pharmacies. And so many of the worries that we had going into it, that these would be vulnerable populations, that these would be ethnic minorities, that these would be poor individuals trying to escape a situation rapidly so that they didn't burden their families, really haven't come true for many, many reasons. And I'm not saying that these aren't real concerns. These absolutely are, and we need to take them very seriously. And it's offensive that people wouldn't have great access to health care from beginning to end. But I would just say that that some individuals have raised to me the greater concern that those people don't have the same access that people on the other side of the state have, and I think that's quite an interesting perspective that I wouldn't, in the first days have imagined. So many of the things we think are not actually true in some ways about this law.
I just want to thank all of our panelists, not only for presenting, but also for flying here to share their experiences with us. So thank you so much.